Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine Podcast. I'm your host, Yaron Ivan, as usual, and today we have some very exciting news. Starting today, and hopefully on a regular basis, Dr. Jay Fisher, who is a very experienced PEM clinician in California, will be hosting a regular segment on PEM Rules that is called Dr. Jay Fisher's List of I Never Want to Miss It. On that segment, Dr. Fisher will pick some kind of serious, significant surgical etiology that we as PEM clinicians never want to miss. He will review the literature and, more importantly, discuss about his experience diagnosing and treating that condition. I think this is a great way to learn from other clinicians as opposed to reading a book chapter, reading an article, or even doing your own research. One of the ways that I like to learn the best is learn from other people's experiences. And Dr. Jay Fisher is a great person to learn from. So in today's episode number 1 of Dr. Fisher's list of I Never Want to Miss It, we will be discussing intussusception. So welcome, Jay, back to the show. I am super excited that we're going to get this started. I got to tell you, I've known you just for a few years, but to me, you represent one of the forefathers of pediatric emergency medicine in this country. So I'm super excited. We're all going to learn from your experience. And you don't really need much of an introduction. I'm just going to say Jay Fisher is a pediatric emergency doctor, and you've been practicing since 1992 as an attending. Is that right?
That's right, yeah.
Right. And for many years, 28 or 29 years, you were here in Las Vegas as the facility director at UNLV. Is that right?
Yeah, even before it was UNLV, actually, but yeah.
Right, before that medical school even existed. You finished your training in Boston, Massachusetts. And I'm just going to say, Jay has been on the show twice. And between those two episodes, you've had over 500 listeners from 19 countries and all 50 states. So a lot of people have learned from your experience. I'm super excited we're going to do that. Today, we're going to talk about something that sits on my list, and I'm sure everybody's list of I never want to miss it, and that is intussusception. So good morning, Jay, and how are you?
I'm great. Thank you so much. This is really exciting. Those numbers are really fun, impressive. It really is exciting. And I think what you're doing is amazing, and thank you so much for having me.
No, thank you, and thank you for coming on the show again, and I'm super excited. We're going to make this a regular thing. So teach us from the books, and mostly I want to hear from your experience about intussusception.
Oh, yeah, great. It is one of the diagnoses you don't want to miss. And it's one of the conditions that peds emergency medicine has made a huge impact on. If you look at some of the data over the last century, say, for example. So it's really exciting to me. It's really a great peds emergency medicine diagnosis to hunt. And I think that there's I'm still learning about it, and it's really fun to talk about. So the condition of intussusception, I got a hold of a paper from the 1920s, so almost the pre-antibiotic era, from I believe it's either the Annals, the Archives of Surgery. And back then, not surprisingly, I guess, the mortality in that condition was about 50%. And if you look, even current day in third world countries like sub-Saharan Africa, the mortality is still about 10 to 20%. And it all has to do with access to care and how quickly you make the diagnosis, because the intussusception of a small bowel into the large bowel, past the cecal valve, results in local ischemia and the chance for ischemic bowel and all the complications subsequent to that. And early diagnosis and intervention is one of the key determinants. And of course, now in this country, the mortality is less than 1%, but still there. And and then also morbidity with loss of bowel. I don't have an exact number for that, but that's a sizable number of kids whose lives are unalterably changed by the delayed diagnosis. So the classic teaching is this triad of abdominal pain, blood in the stool, and palpable mass, and some say colicky pain. But as you know as well as I, that waiting for that trifecta to occur or triad to occur is fool's gold. And if you wait for that, you're making a dreadful error in that patient's care. So I think our job, as we plow through all these kids, I don't know about you in Vegas, but right now in California, we're just having a terrible little norovirus outbreak. And of course, there's always, even with the vaccine, there's a rotavirus out there, an enterovirus, and all these other adenovirus, all these other GI pathogens that bring countless little kids into the ED with vomiting. And, trying to pick the needle out of the haystack of which one of the 1,000 has intussusception when all these kids are having vagal reactions to their gastrointestinal discomfort and repetitive vomiting, and they come in pale and not looking great. It's really a challenge, particularly in that young infant and toddler age group, which is where the disease process is most prominent. So it's a real challenge. It brings to the table all the skills that you want to possess as a peds emergency physician, and it will challenge you each and every day, as it did for me yesterday. So,
yeah, and I couldn't agree more. And I think, kind of like you discussed, we diagnosed it earlier in the U.S., so we don't get to that. Thank God we don't get to that triad. I personally found, like you said, we have to use all of our skills. I personally found over the years that the most important skill in potentially finding intussusception is history. So when I ask the parent or the caregiver, does your child seem to be in pain and then he's fine, and then he's in pain and then he's fine again? If the answer to that is yes, and again in the right age and whatnot, in my mind, the kid has earned an ultrasound for intussusception. Over the years, I've been wrong many times because constipation has the same kind of pain pattern in my experience. But if they say yes to that question, the kid gets an ultrasound, and many times I've been successful in diagnosing intussusception.
right. As some people that have trained with me know, I have been bamboozled by constipation many times in the past, and I make a joke and say that the diagnosis of constipation should only be made in someone who comes in saying, "I can't poop," or "It hurts to poop, and can you help me get the poop out?" That's the person to make the diagnosis of constipation. Everybody else, you can manage the constipation, you can manage the slow transit time, but don't make that diagnosis. And if you put that diagnosis in your Epic or whatever, a bolt of lightning should come through your skull and say, "Stop, don't do that." Because the group up in, I think it's Toronto, that Stephen Friedman researcher, I think his name is Dr. Friedman, who's just one of the best peds emergency medicine researchers that no one's ever heard of, has done all this great work on the fool's gold that is constipation, and how 1 in 300 people we sent home with constipation, at least under his study, is got another diagnosis that's more important. So be careful with the constipation. But yeah, I agree with you. And then the other thing, I think one of the other reasons I want to get on the podcast with you is to encourage everybody to take a look at that study published in Peds Emergency Care. I think it was 2020 by the group from Children's of Boston that looked at the variation and presentation of intussusception by age. And what they discovered is, and this is the kind of research I love, which is just basically experiential research, which allows you to say, well, I've only seen 3 intussusception cases in the last 5 years. Well, I get to read about how all the other doctors made 100 diagnoses of intussusception. And in their beautiful study, what it demonstrated is that crampy abdominal pain thing is not so much a thing under age 2. There was really a bifurcation in the symptom complex at the age of 2. And they demonstrated that very elegantly in that study. And so I'd encourage everyone to look there. The first author is Kimia, Kimia. So yeah, in that study, some of the things that we all rely on, like that intermittent crampy colicky abdominal pain, was not where the money was in the kids under 2. And that's been my personal experience. I've had a couple of kids with the diagnosis presenting the way you described the crampy abdominal pain, but I've had much more kids with just isolated vomiting, and maybe you hear the word lethargy or sleepiness, and that should be, the bells should go off there.
Very good. Yeah, and I remember also in fellowship being surprised by it, but I remember my director teaching me, she kind of phrase it very simply, that intussusceptions should be on the differential diagnosis of any baby or toddler with altered mental status, which really, for many of us, doesn't make a whole lot of sense. It's an intestinal problem. Why would the kid be altered, etc.? But absolutely, it sits on my list of I never want to miss it. And it sits on my differential on, again, in the appropriate age with any child with altered mental status. Couldn't agree more.
So one of my favorite cases was my first intussusception case. I was a second-year resident, 1988, in the old Boston City Hospital, and we had just gotten CAT scanning. CAT scanning was a brand new thing, and we used to have to call the radiologist to ask them for permission to do a CAT scan of the head. And I had a 1-year-old that had an altered mental status, and it was late in the evening. And I said, I have no idea why this kid has altered mental status. He's floppy, he's pale. I'm going to send him to CAT scan. And the radiologist said, okay, sure. And the kiddo was literally on the way to the CAT scanner and had a massive bloody stool. And we stopped the presses there and began working that up, and he had intussusception. So that was my introduction to intussusception. And I believe it was Fred Henredig, I think that's the author from Children's of Philadelphia, who wrote one of the first papers about altered mental status being the initial presentation. I think he published it in Clinical Pediatrics around 1990 or so, and about the initial description of altered mental status. And other people have done great work on how there's some type of internal opioid or mu receptor that gets stimulated, and that's what causes the alteration in mental status. Yeah.
Very interesting. Now, I know you also wanted to talk a little bit, Jay, about the use of ultrasound or the efficacy of ultrasound in making the diagnosis. What do you have to tell us about that?
Yes, I wish I was an ultrasonographer. I am not. But I have, luckily where I practice now at Rady Children's, we have these amazing pediatric ultrasonographers and we have amazing access to them. And so it's so easy to access them. But I'll tell you that anyway, but if you have the ability, Dr. Arroyo and all those great ultrasonographers all over the country, we have one here at Rady as well. And there's been a multi-center study published in Annals of Emergency Medicine in 2020 that looked at a non-inferiority of POCUS versus radiology scanning, and showed that the people that are good at it are just as good at the bedside. And yes, if you have the means and the ability to be able to look at that right lower quadrant and identify the kidney sign or the target sign, I think we should be doing that just about every kid with isolated vomiting. That's probably the best way to not delay the diagnosis. But that takes great skill, and I think we're not quite there yet, even with the best of POCUS. I think the conclusion from that study, that multi-center study in Annals of Emergency Medicine, the conclusion was we need more studies, because I think the N in that case was only 60 or so, so not enough to say with confidence intervals that bedside is just as good as the real thing. But yeah, I mean, those guys, people that are good at it, that's the way to go, is to look in that right lower quadrant and or right upper quadrant or wherever, and find the intussusceptum that way. This is an area again where the new PZM doc is really good at being able to identify that, and they should be able to get close to zero misses if they're that good at it,
No, I agree. And I got to say, just about that, I was recently in a medical mission abroad where in .ER, POCUS is very common. And we had a kid with a very compelling story. And right next to me, the attending grabbed the ultrasound machine and scanned the child. And lo and behold, we saw the target sign. And I did learn how to do that in fellowship. I got to say, finding intussusception on POCUS is not so difficult and so challenging. I don't think it needs much over practice. Over the years as an attending, I never had to use it because I would just send the kids to the radiology department and get an answer quite quickly. But, unlike appendicitis, for example, finding intussusception on bedside ultrasound, I don't think it's very challenging. So I hope it's something that many of us can acquire over the years and hopefully make it more standard of care and diagnose it faster.
Right. I mean, I actually have made the diagnosis one time years ago when we first got ultrasound in Las Vegas. And so, yeah, but the thing that's interesting in that case is that what does it add to my clinical exam? In that patient, I knew the patient had intussusception clinically. I was like almost certain. So it was nice to confirm. But it's the occult cases that are the ones that you wish, you were great at. And then you talk about confidence intervals and do you feel confident enough to send somebody home? So I think it's one of those tests where it's helpful if it's positive at the bedside. Is it helpful if it's negative? That's the thing. That's when you got to really be good.
Yeah, no, I agree. I also
Oh,
I also tell you, Jay, again, just anecdotally, my personal experience with two cases of interception where really the physical exam was quite reassuring and the kid looked well on two separate cases in two separate ERs. One of the parents had a little green staining on their shirt. And when I asked the parent, is that the color of your child's vomit? And they both said yes. And I immediately, like a kind of a light went in my head. This is bilious emesis. This is small bowel obstruction and interception until proven otherwise. And lo and behold, both of those kids, again, two separate ERs, two separate times, had interception. So not only it's good to ask about bilious emesis, sometimes you can actually see it on the parents' shirts, I guess.
I love stories like that, Jerome, because that's exactly it. I mean, we have all these algorithms to make diagnoses. And where in the algorithm is, oh, I saw a speckle of green on the left shoulder of the mother. that's
Right.
not that's not in too many algorithms. And so good for you. And that's the kind of detective work that sometimes is required. I'll go the other way too. I want to bring up two other things. I was duped recently, sort of, by a kid who I clinically had a high suspicion of intussusception. Came in 18-month-old, pale, vomiting, having pain, a little bit of distended abdomen, very sudden at onset. And I said, this is not likely to be. It was in the middle of a norovirus outbreak. And I was like, but this is something different about this kid. But this kid was triaged as a level, I think, 3 or 4, came back to a non-acute area of the ED. And it was busy. And I ordered the formal ultrasound. And lo and behold, it was a sign out. I signed the kid out. And things took a little time. Nurses were changing too, et cetera. And lo and behold, that patient did not have intussusception, which is, for you and I, it's a once or twice a year diagnosis. This was a once in a career type of diagnosis. And it was an internal hernia. And this kiddo crashed dramatically. So even when you clinically think you got the diagnosis, lo and behold, ultrasound was negative in that patient. And while they were ultrasounding the kid became shocky and had to be resuscitated, intubated even, and it had an internal hernia. Which I've only seen in 32 years of practice, I think twice or 3 times total. And so, you never know with this profession.
Yeah, no, that does sound like a very unusual, challenging case. Always goes back to rule number one. It's not the patient's job to prove that they're sick. It's your job to prove that they're not. I don't always find the problem, but I got to make sure I try to prove patient is not sick. And if the kid is sick, I resuscitate, consult, admit, etc. But that's a very sounds like a very challenging case. I know, Jay, you kind of put together some tips from the literature again, going back sort of to the basics and to the research and to the non-anecdotal experience. You put some tips together for us PEM physicians to learn from.
Yeah, let's go through those. So number one is that great study from Children's of Boston, experiential observational data, which showed that kids under 2 present different than kids over 2. And the kids under 2 were less likely to have crampy abdominal pain and irritability, and more cases of isolated vomiting and altered mental status as the main presentations. Also, other research has shown that several studies have shown that blood in the stool does not have much predictive value, positively or negatively, to help you with this condition, unfortunately. And then the other thing that's been shown several times over is that your plain radiograph, if you don't have quick access to a ultrasonographer, plain radiographs can be helpful with abnormalities seen in 80 to 90% of kids, which is nice, helpful.
Yeah, and
And
that's a
then,
very, very, very helpful tool for those who work in the community and may not have an ultrasonographer, or if it's in the middle of the night. So that's a very, very actually very important tip to know.
yep. And then if you don't have a ped surgeon sleeping down the hall, it's also nice to know that there's this new intervention that several people have studied. I know the group in South Carolina studied this, and I think also in Austin, looking at delayed repeat barium enema. So it's always tough at 2 a.m. A kid who doesn't look that bad, but has intussusception, radiologist moves the intussusceptum initially, but doesn't get it completely reduced. Is that a patient, the surgeon's telling you over the phone, I don't want to come in at 2 a.m. Why can't I wait till the morning to have my full team with me? And those kids that have soft abdomens and good pulses and who are alert, there is some nice data out there that you can do this delayed repeat barium enema in a selected group, provided you have a surgeon closely at your beck and call. And you can perhaps reduce the number of kids that have to go to OR with that delayed repeat barium enema or air enema within a couple of hours of the initial one. So that's research worth looking at. And then lastly, there's this, as we're doing more ultrasounds, we're finding more and more about this ileal intussusception, which is many times a thing that's probably happening to a lot of our kids with gastroenteritis, and it can be benign. But I'm also aware of a case of a kid where the ileal segment was a little bit large, perhaps over 4 centimeters, and there's some data out there now saying we probably should quantify these cases. And is the intussusceptum more than 4 centimeters in size? Is the patient having persistent pain and tenderness? And in those patients, those basically do not reduce with enema and are going to require a surgical consultation. So that's a little tidbit if you haven't seen. I've only seen a handful of those, but those are also ones you should know about.
Yeah, I think the whole topic of small bowel to small bowel interception is really quite fascinating. I feel like I sometimes tell the residents it's really just fancy abdominal pain. It's abdominal pain that we're able to pinpoint, but I'm not surprised that maybe a small percentage of those kids actually have a possible surgical problem. So that's very interesting to know. It's kind of a fascinating topic that is always comes about every once in a while.
Yeah, I agree. Literature on this, peds emergency medicine physicians have made a huge impact on this. And if you have a boring afternoon someday, just go to PubMed and type in intussusception and select 0 to 18 years. You'll find all kinds of great stuff about. And if you want to broaden your experience and now have the information on 500 kids with intussusception, because we only each see a few of them, it's a great way to do it.
Yeah, I agree. Jay, thank you very, very much for coming on the show. This is super helpful, and I'm very, very happy we're going to do this more consistently every once in a while. I'm excited to have you as a regular on the show to discuss exactly those challenging cases, and more importantly, to hear from you as a very experienced provider about your experience and what can we do to be better at what we do. Um, Not surprisingly, I guess this is your third time on PEM Rules, and yet again, you're asking for an AC/DC outro. Is that right?
I am.
You really like AC/DC.
I do like AC/DC. I do. I want to make one more point. You're very gracious to me and very complimentary, but I'm not a real forefather. My certificate number is 314, I think. So there was 313 people ahead of me. And actually, the real fathers of this field, Gary Fleischer and the group at Children's of Philadelphia, I feel I have so much deference to them, Dr. Baker, all those people, that I don't feel like I should be in the same conversation as those types of people. I really appreciate those kind words, but in reality, I'm just a working stiff, just like everybody else. So,
Well, we appreciate your contribution, and I know some of the people who know you and speak highly of you, and I know some of the people who trained in Boston. Actually, had the honor of meeting Dr. Stephen Ludwig, and some of the other big forefathers in pediatric emergency medicine. But I think the contribution that many of you guys have made to the field is really impressive, and we appreciate it as the younger generation because we learn from the best, and that's always good. And again, thank you very much for coming on the show. Here is my best attempt to do Rock and Roll and Noise Pollution by AC/DC. That's the one you requested, right?
That's the right. I love that one.
Okay, I feel like I'm going to know AC/DC very well in a year or two when we've had many more episodes, hopefully with you coming on the show. Thank you very much, Jay, and have a great day. And that is it for today, guys. Thank you very much for listening to PEM Rules. I really hope you learned from Jay Fisher and his extensive experience. And again, I'm super excited to have this regular segment on PEM Rules from now on, hopefully for a very long time. We're going to call it My List of I Never Want to Miss It with Dr. Jay Fisher. Thanks again for listening and have a great day.